And the cost of maternal smoking increased the risk of admission to the NICU by almost 20%. It increases length of stay. It's $3,600 per night. So smoking attributable expenses for NICU costs are estimated at $149 million. So that's just another way of thinking about this problem in terms of cost alone. Now, the late outcomes, I'm going to talk a little bit about them because I think that people need to know about this. Behavioral, cognitive, so we talked about the neonatal brain and the nicotine receptors and epigenetics and all these things. So it would make sense that there would be some late problems from smoking because some of this stuff doesn't go away. If your brain receptors and nicotine from the very beginning, who knows? So again, no randomized controlled studies. All of this is observational. And of course, you have to control for lots of variables. Several well-controlled studies have shown significant relationships between smoking during pregnancy and external behavior problems in ADHD. There's often a dose-response relationship, and even severe antisocial behavior is related to smoking during pregnancy. And scarily enough, this relationship has been observed with moms who are wholly secondhand smoke exposed. So they themselves are not smoking, but people around them are smoking, and sometimes these relationships have been shown. Nicotine exposure, again, per se, has been linked to externalizing behavior problems in the offspring. So this would include direct smoking, secondhand exposure during pregnancy, use of non-combustible nicotine products, and I would include cigarettes with that, and even the use of nicotine replacement therapy during pregnancy. So these later effects seem to be nicotine related. Yeah.
So, I mean, my understanding is even just looking at outcome measures, behavioral outcome measures, just for the premature babies, do they look at the difference between the premature alone versus premature and smokers?
So these studies have control for gestational age. So I couldn't say whether there's a separate study in premature alone, but when they do this, they will not include all the preemies. They will either they will be excluded from the epidemiological study or they'll control for it, but it's not an effect of prematurity. It's definitely that's pretty much. Any other questions right now? So to hedge it a little bit, both human and animal studies have failed to prove clear evidence of causality, again, because it's all associational, but the linkage is biologically plausible. Again, I would say definitely something we should consider. In one particular study in Norway with over 22,500 people, they were externalizing behavior problems in kids whose moms had smoked more than 10 cigarettes per day, and also in 4-year-olds from 2 birth cohorts. And so when you think about these European studies with sociodemographics that are very different from the United States and even holds up there in these really large populations, I think it really gives us pause that people really know about this. The cognitive outcomes are inconclusive for the same reason, because you have to control for so many other variables. The confounding variables are maternal age, education, IQ, socioeconomic status. But in one perspective, British cohort, in utero smoking was related to impaired reading performance and increased risk of language impairment. So again, I don't think it's helping anybody's cognitive. Well, what about obesity? And that one is really interesting. So there's a huge epidemiological literature, but just this one study, 2002, they adjusted for parental education, the BMI parents, birth weight above 90%, breastfeeding, snacking, watching TV, video games. Because you could say that the moms who smoked in pregnancy were not going to provide any home environments. Of course, they're going to be this. But even when they threw all this into the equation, the risk of being overweight was about 40% greater, and the risk of being obese was about just 2 times higher. So what did you say to me that weren't these babies more small? Isn't there a greater risk of overweight among these babies? Well, yeah. So has anybody ever heard of the phenotype, the Barker hypothesis? So the Barker hypothesis, I think Barker was an epidemiologist in England, and I think it was observational. Basically, my understanding, but maybe you can help me with it, is that people that grew up in famine or were very young babies during, I think, the end of World War II, which just wasn't enough through maybe World War II, that they had this huge risk of becoming obese later in life. And there wasn't really a pathophysiology was epidemiologic, but it has stood up. And so what could be happening is really this epigenetic changes. So if you're born, and remember that babies have placental insufficiency most likely if they'll smoke because of vasoconstriction of the placenta and uterus. So if your gestation is in an environment like that, and if we have any kind of genes that we can turn on to suck up all the nutrients that we need, well, then you're going to get these epigenetic changes. And the problem is that once you're born, you're not in that environment anymore. You're in a food-saturated environment. So it actually makes a lot of sense that those kids are going to have a much higher risk of becoming obese later in life. And I've been at meetings, obesity meetings, which clearly put maternal smoking as one of several modifiable risk factors for childhood obesity. So like, this is out there, and this is definitely stood up a little bit more than the cognitive issues to data that should be close, not true. What about the pregnant non-smoker exposed to secondhand smoke? Well, in terms of global health, it's more than a third of women in the world. Think of places like China where like about 90% of the men smoke, then women smoke, the women are pregnant, they're going to get exposed. The risk of low birth weight is not terrible, it's 1.2, it's significant. A slight increase with stillbirth, preterm delivery, and congenital malformations, and some evidence of cognitive issues. And apparently, these findings are exacerbated in conditions of maternal hardship, so where they're already not getting enough nutrition, this added risk factor of being exposed to secondhand smoking if you're not direct is problematic for this global population. What about e-cigarettes? I've mentioned e-cigarettes. So what about e-cigarette use during or after pregnancy? So we already mentioned and established that nicotine itself is problematic during pregnancy. So an alternative source doesn't really solve those issues. You're not going to get all those oxidizing gases because you're going to get a huge dose of nicotine. There's lots of dual users of both that we continue to grow during pregnancy. And the aerosol itself is also not benign. So do not recommend that women switch to cigarettes during pregnancy. Okay, so we're going to switch a little bit to talk a tiny bit about the e-cigarette, not per se, but the vapor. So the e-cigarette companies have tried to tell everybody that it's only water vapor and to tell smoking fans to piss off. But this is a picture of a vaping contest. This is only vaping 2 p.m. when the sun's supposed to be shining. And she goes, so you can see that quite a lot. A bunch of people that are vaping contest. So what's in the e-cigarette is liquid nicotine plus humectant to keep it moist, which is either propylene glycol or glycerin, and some flavoring agents. The flavoring agents are safe to keep your drink, but they haven't done research on what it's like to inhale them. And so what happens is that there's chemical reactions, and I believe the glycerin and propylene glycol can turn to either acetylene, acetaldehyde, formaldehyde, and acetone, which are definitely not safe. There's also small amounts of carcinogens from nicotine breakdown and nitrosamines, and then there's also polycyclic aromatic hydrocarbons. So all these things are actually known in nicotine that comes from these cigarettes. And basically, it seems that and there's just an emerging literature that the effect of e-cigarette vapor is to cause a lot of problems to the vasculature. So what's emerging right now is that the risk of cancers from e-cigarettes is probably much lower than traditional cigarettes, but the risk of heart disease, both from the vapor and from the person who actually uses it, is probably going to be similar to traditional cigarettes. Mention this. Okay, so first of all, this is not a meeting. I know gynecologists, but I always wonder whether or not we as the AP could start some work with our gynecological colleagues to try to think about smoking, smoking before we see those babies. Because what I basically have told you is a lot of the problems are already kind of, nailed down ready by the time the baby's born and things change with their pregnancy. Teachable moments for the gynecologist would be preconception care, all gynecology and primary care visits, definitely helping her quit during pregnancy, no matter how far along she is, to at least ask them to have a smoke-free home in car during pregnancy, avoid public places in the workplace where there's smoking, avoid secondhand smoke. And if a mom has quit during pregnancy, then you have to really have the discussion with her. In the third trimester, like you quit during pregnancy, don't go back to this. It's common people will quit during pregnancy and go back to this. About 10 to 40% of pregnant smokers actually put the first prenatal visit. They tend to be less addicted than the other ones, more concerned about fetal effects. Really prenatal care. It's also more nauseous, so maybe the nausea itself makes them feel like some people probably just make them more nauseous. So that okay, so postpartum opportunity would be, first of all, during the hospital stay, so the pediatrician is making rounds on them until they want to ask if they had smoked prior to pregnancy. Home visitation, first pediatric appointment, WIC services have been involved in helping women stay smoke-free. Followed by the clip line, postpartum check as for the OBGYN, and at least asking for a smoke-free for the car. Well, if you quit during pregnancy, as many as 60% return to smoking within 1 year. So this is where pediatricians can also really come in. It's very important. And the OBGYNs, as I mentioned before, because you really want to know, oh, I quit, but as soon as this baby's born, I'm going to be right out there. Your anecdotal versus telling you about your moms who the babies and the nurse who get outside. Smoking, right home, if they're allowed to. And that's not a really good sign. So you can get people who have quit during pregnancy, really encourage them to stay quit. It's kind of like a deal they make with themselves. They make the deal just as soon as they more than none, or think of it as a long-range process. So our role is to screen for current and past tobacco use. So if we don't ask people if they smoke prior to the pregnancy, that they're current smokers, right, when the baby's born or the newborn visit, we're going to miss an opportunity. And so we definitely want to ask people what their practice was in terms of smoking before they got pregnant. So we'll come back to this. So we know that brief interventions to help people quit smoking that last 3 minutes or less actually do increase abstinence. So every tobacco user should be offered at least minimal intervention with the sheet is referred to next intervention. So in adult medicine, when they're dealing with direct smoker, they have 5 A's: ask, advise, assess, assist, and arrange. And for pediatrics, a lot of times what we try to do is make it simpler: ask, advise, and refer. Now, has anybody here in the audience taken motivation therapy training? So we know that MI is something that we can do with a lot of different problems. It works on facilitating and engaging intrinsic motivation for the client to change behavior. It's very goal-oriented and client-centered. So one of the things that we always want to do with the smoker is to assess the stage of readiness, to expect resistance, and to personalize the message. So obviously, if a person is really not ready to quit, if they're in the pre-contemplation stage, referring them to a quit line is probably not going to help them. But personalizing the message is always important. And I'll just state that personally, we all know that when we take these MI classes, they want you to do the whole thing. You talk the whole thing. You're going to talk about the rulers. So everybody know what I'm talking about, like how much do you want to change? It was a 7, but why not an 8? Why not a 10? If you think you could change, it's a 2. Why not a 5? All right, that isn't how you're going to work it out. That is not going to happen. So I think a lot of people, when they think about MI, they just think like, I can't do that with my patient because I don't have an hour to sit there with the rulers and going through these different things. No, you can't. I think there's a lot of MI principles that you can use in a really short time that may be more helpful than you really can believe. So one of them, I didn't put in the slides, but I really believe in this, is to ask permission. Because if you have a kid, let's say, or you have a newborn and the mom's already smoking, she's smoking pregnancy, just say, can we talk about your smoking and its relation to your child? And that opens up a discussion. Either she just says no, in which case you save yourself a lot of time because you're not going to get rid of her. But if she says yes, by you asking permission, it's actually a way of opening up a conversation that you wouldn't have before. Expecting resistance and not expecting that she's going to be changing just because you're having a conversation is very important. And then personalizing the message to her about what could be important about the child's smoking. So I think we can just use little mini MI principles in very short times of interventions without thinking about having a whole session. Very helpful. So the ask. So just remember what I said before. There's just different ways of thinking about this. There's different concepts. So when you ask shortly after birth, it's have you ever smoked? And the answer would be I've never been a smoker, or I've smoked. We don't have to say 100 cigarettes. But the two other options could be I smoked before I found out I was pregnant and I'm not smoking now, or I stopped smoking after I found out I was pregnant and I'm not smoking now. So those two boxes to the right are very different from the other box. Those people are in a different situation. So you definitely want to congratulate the patient who had been smoking prior to birth pregnancy, discuss avoiding triggers to resume smoking, and even offer the quit line, which can do some relapse prevention, because that person who had quit before the pregnancy is not the same as the person who had never smoked. But we as pediatricians might not realize it if we don't even ask, because currently she's not a smoker, but we don't know what's going to happen. We suspect she will go back to smoking. It's stressful to have a baby. What is the advise? A big ask. The advise is strongly advise every tobacco user to quit, provide information about cessation to all tobacco users, strongly urge smoking on some cars, look for teachable weapons, personalize the risk, and document your advice. And the refer is the quit line, which is a very convenient way for busy practitioners to give something and offer something good to the smoker. And we mentioned the pre-contemplators. So with them, you're not going to spend a lot of time trying to convince them to quit, but give them a handout, give them something to take home to them. Because your job may be that they may or may not, they may throw it out, who knows. The next time they come back, you may be able to move them down and continue on. And then after the next discussion, you may be shocked, but in a year, they may be ready to actually quit. And we're going to hear more from Mike Gilman in a little bit. I think what the whole presentation is done with about the smoke-free families within the academy, so people are interested more in what they can do. There's a lot more that the Ohio Academy can offer us. So let me tell you a bit more about that. We mentioned the quit lines, there's advantages, they're accessible, nobody wants to go to a group to quit smoking anymore. There's no cost, they're easy interventions for us to send people to. And in Ohio, they can give up to 1 month free nicotine replacement to smokers. There's also text to quit, which is very interesting, and a website. Smokefree.gov is a very good website for patients. I've looked into it. If you're a pregnant woman, they have a special part of the site. If you're a teenager, there's a special part. So it's not just for all smokers, it's tailored. There is a text to quit line. I tried that myself. Not that I smoke, but I wanted to see how it works. And I think that's very useful because so many people like to text. So they asked me how many cigarettes I smoked per day, so I made something up, and they asked me what I wanted to quit. I made something up, and then a week before I wanted to quit, they started texting me about going away my cigarettes and letting my intentions go out, tell my friends that I wasn't going to smoke anymore. And then they checked in with me. They gave me the number of the quit line, and they checked in with me with supported text, which is another alternative, I think, because that's just a motive. This is how you can introduce the quit line. You can personalize it. This is very helpful to you. It's a free service. You can learn as much as you can about the more you know, the more successful. So try to be supportive when you give these referrals. And one thing I'm just going to state before we conclude is that a lot of people, when they do start talking to you about their smoking, there's a lot of shame about it because they know it's not really good for them. They know it's not really good for their kids. And many of them have made quit attempts before and have not done very well with those because something happened. So you might hear, like, I quit smoking a few years ago for 6 months, but then my mom got sick and passed away, and it was just too much help. And that's real. So one of the really, really interesting facts about this is that the more someone has tried to quit smoking, the actual, it's not a perspective for failure, it's a positive factor for success. So if you reframe their failure to them as not a failure, but if you say, hey, that was just a practice session, it's really great that you tried, and you know you're going to be ready to try again whenever you're ready, I'm going to help you, that changes the conversation from one where the person feels shamed, put down, nagged, to something much more supportive, which I think is something that we really have to think about when we're trying to change behavior that is addictive. So my conclusions are that smoking during pregnancy is increasingly a health risk and a health outcome disparity. There are lifelong consequences. There are opportunities for collaboration between pediatricians and gynes. Remember that new moms do become pregnant again, so that if they're to prevent all the costs of the next baby that they may be having, and consider incorporating screening and referring your packages into your body initiatives. Maybe hearing a little more about that. So that.
What's the percentage of Congress who smoke?
I don't know. Anybody? I don't know.
I'm curious. I look at it,
So I don't know the answer to that. I mean, state on that smoking, even there's an socioeconomic status. So I'm just going to get out of the state that representatives who come from 4 districts of the state represent a higher SCS. I don't know. I'm just going to get
Judy, that's like you get your camera, she was at Channel 10, this pastor, she was the poster child for it fit longer.
Yes.
She smoked.
Oh,
And
that's
she
why
was
she
very
was
careful
so
to never get Facebook smoking. And she always saying she would never be seen at the beer bar.
That's why she was so skinny. She was smoking. Any other questions? Yeah. Okay, so breastfeeding services kind of first of all, you guys want to population, just in general, people who are very into the health of their child tend not to be people in this one. However, what happens if you do have a mom who is a smoker and who wants to breastfeed? First of all, what would you tell her to do? Absolutely. Yeah. And you don't tell her to dump out the milk or anything like that. So the breastfeeding is greater than the smoking breast. Does it keep people from smoking? I think it's really hard to answer that because I think the populations are so different, but occasionally you have someone that's in that little Venn diagram with two things that don't go together. But I don't physiologically, what do you think? Okay, but then which way do they go? For the breastfeeding or the smoking? Well, there you go. Yeah, so basically, I would go, should say that it's still protected. That's something you don't see that to see, right?
How do you advise that be reassured that the principal has signed with the person?
Okay, well, one thing I didn't mention was how to ask general, I apologize for that. So we find that if we ask if a child is exposed to tobacco, then they're going to say no because they're going to say they smoke outside. So I'm trying to use the question, just any years to be a child or smoker, years to be a child So some of my research has looked at why it's told maybe this just outside. And it's not as high as the ones who say that they smoke inside, but it's still not negative. So number one, what's going on? Well, first of all, there's some deception involved, which is sexual desirability. In other words, I'm not going to tell you nutrition. So they're pretty bad. They could be smoking outside and inside, so it's truthful if you just smoke outside, and it's when it's 2 degrees outside, you can also smoke inside. They could smoke back or could put all the tobacco when they rush in. Or you can do the burning, so you can some dust and stuff like that everywhere. So there's a lot of reasons. The other thing that I feel strongly about is like, parents, how old are they? They're like 21, 25. They're young. And then it's kind of like it's important that they become non-smokers because they want to live longer than necessary for a lot. They can be dead in the courts. It's not wrong to say that. I hear about it too. And the other thing is that kids who grow up in homes of smoking are not themselves. So I think we should have conversation. Like, do you have a comment on that?
Yeah, I had two comments and one question. One comment is we're often asked by physicians say, there's so much to talk about. How can I put this into my daily routine? And I always look at it and say the things that cause the greatest morbidity and mortality are things that we really need to address. And this causes a significant amount of morbidity to the children. And so it's definitely something that we should find a way to put into our practice. I think the idea of getting people to quit, what we found in behavioral change counseling is you don't have to go through a whole motivational interviewing, but one, to get an idea of what stage, how ready are they for that change, and then giving them some type of plan. Like, hey, over the next week, I'd love for you to do this. When you come back, here's where you're at. You could send text messages, reminders to get them on that way. And if you outline the plan for them, they're so much more successful of it happening. The question I have for you is, do we know what amount or what percentage of pediatricians actually do screen or discuss smoking with families?
Well, what I can tell you is that if you ask pediatricians if they do that, the AP does that survey, what's that called? Periodic survey. Yeah, and they asked pediatricians whether they asked, and it was like a lot of pediatricians, I don't remember offhand, they said they did. But then when they did a survey of people, somebody else did a survey of people, whether they were told by their child's doctor, it was like orders of magnitude less. So either there's a lot of social desirability, either among the pediatricians reporting they did, or maybe they thought they did, or maybe the parents didn't hear it. But there's this huge gap between what people say they do, the professionals say they do, and what the pediatricians or the families say. Like a gap of like 60% or something like that. But the AAP does do these periodic surveys, and that's been published. I think it got published in Academic Peaks a couple of years ago, but I don't remember. It's a great question, the specific number of pediatricians. But just because pediatricians say they do, it doesn't mean that people are hearing it.
In medicine world, we can charge for smoking cessation. Do we still charge for it in pediatric world?
Okay, this is good because I just talked to the coding and billing person from the AAP on this. You can only charge for time if the mother is the person that you are counseling. You cannot bill for counseling, that counseling code, because she is not the smoker. But you can bill for time if you add a significant amount of time to your visit. You know how it goes if you add 50% more, like if it's a level 3 and then you spend more than 50% counseling, when you document that you spent more time, and then you can bill that way. If it's a teenager, which is a little separate from this talk, and a teenager is the smoker or the vapor, then you can add a 25 modifier with the counselor. There's a tobacco counselor, depending on how much time, and it depends on how much time you do. So I think I got that one straight. Does that sound right to you?
Yes, although I'm questioning that as I think about it. She said you can, if you just have the mother there.
Only you can only bill as time. You can't bill as counseling.
Right. you can bill it as time, but that's based on counseling and coordinated care.
You're allowed.
It's patient and or family, so
Yes.
I would think you could.
You could, but you can't use the counseling code you used to use the time.
You're using the time-based code,
Yes,
using it based on time spent in counseling.
yes, and you're allowed to do that. You cannot put on a there's tobacco counseling code. And you can only put that on, yes, you can only put that on if you have like an actual smoker. But if you spend a lot of time with a mom doing this and you document that you spent X amount of time in, then you can bill it that way. Yeah, and you spend a lot more time. Yes, exactly. And you document it. Any other questions? Charles.
Judy, can you just enlighten us on what we're doing in the primary care network with the screening by our nursing staff?
Yeah, okay,
How
so,
that can helps facilitate some of that.
so it's been in primary care nationwide, we have this huge primary care network, and, there's like QI du jour, whatever, we have a million different things that we're doing. But one of my colleagues, Jake Bowman, who's not here, came up with this great idea that we did add it to Safe Sleep Screen. So they get 3 questions instead of 2. The first one is, where does your child sleep? And the second is, do they sleep on their back? And the third one is, and these are asked by the nurses, does anybody who lives with your child or cares for your child smoke? And then if any of those are positive, there's like triggers, it gets embedded into the chart. And then the nurses are giving our internal helping hands, which has a lot of information on quitting smoking to those families. And we just started doing that in, right before 2018. So she's still getting data back on that, and I think we're going to have to do a couple tweaks on it. But it was a good step toward incorporating smoking into the Safe Sleep. So we do that from kids 0 to 1. Did you have anything else to add on that? Or?
No, it's just a good way to use other team members in your.
Yeah, and the nurses do it, but I'm proud of it because it really does incorporate the tobacco use into the Safe Sleep, which it really needs to be. Not yet, no, that would be ideal. No, they're supposed to hand out. I mean, there's lots of things that would be like ideal that don't happen yet, because if you could generate a referral to the, but like the barriers for that would be that the mother is not our patient, whereas if it was in an internal medicine practice, that if they could have better documentation. There's a lot of barriers. I think that's a whole separate conversation, but by the mom not being our patient, we have documentation barriers to some extent.
I recommend regarding number of pregnant women who quit smoking during pregnancy. Approximately 5 to 6 years ago, I read one of the emails that feels great. 200 women were had a anonymous survey after their prenatal pregnancy. 30% of 200 of those indicated they were smoking mothers. 35% did not do. They agreed on an anonymous survey based on smoking. But 50%
Oh, yeah, because it's socially desirable and nobody wants to admit to it. Yeah.
Anonymously, they admit.
So we'd say maybe 30 to 50%. We don't really know. Anything else? Okay.
Hello, can everyone hear me? All right. Do I go through the quiz? Well, good afternoon, everyone. Again, my name is Daniel Hurley. I'm with Capital Consulting Group. Our firm has represented AAP for close to 25 years. I definitely have not been there that entire time, but it's actually our firm's first client. So that's something we take very seriously, and we have always enjoyed working with that chapter. I'm just going to give you a little bit of kind of broad political overview to kind of set the context for tobacco cessation policy. We are in the 132nd General Assembly. It's the second session of that General Assembly, which is calendar year 2018. We have General Assemblies on a 2-year cycle, just like Congress works in a 2-year cycle. The second session is always the election year. It's always a lighter calendar because members are off campaigning. Currently, the partisan makeup in the House is 66 Republicans, 32 Democrats, and the Senate is 24 Republicans, 9 Democrats. I can confirm that probably 3 of them are smokers. I don't know about the rest, but when you consider the demographics and statistics around who smokes, I mean, the legislature is disproportionately wealthy white males, so you actually probably have a fairly low smoking rate compared to the general public. Some key issues that you've been reading about in the paper. Education reform, gun control issues, unemployment compensation, payday lending was a big one this week. A lot of healthcare related bills dealing with MOC, bills dealing with scope of practice, things that keep us busy pretty often. Just to touch on key allies we work with when we're talking tobacco cessation, obviously our colleagues in the House Children's Hospital Association, Heart, Lung, and Cancer Associations are the big players in that. Campaign for Tobacco Free Youth. And then a newer organization is Tobacco 21, which we're going to talk more about today. In recent years, in response to I think really good publicity about Ohio's very, very high infant mortality rates, there have been some really good pieces of legislation. Beginning the 130th General Assembly, we saw a tobacco tax increase in the state operating budget. We saw a pair of bills get done related to safe sleep and SIDS reporting, respectively. And then we had House Bill 384, which was ironically a bill we had worked on that did a lot on immunizations, but it also included language establishing the Commission on Infant Mortality. In the previous General Assembly, so this is 2015, 2016, we had an operating budget, no tobacco tax increases in it, but some funding for various infant mortality initiatives. And then the big bill was Senate Bill 332, which was implementing recommendations that have been developed by the Ohio Commission on Infant Mortality. And this was a very long list of, I think, really good reforms. Everything from improved data reporting and collaboration between the Departments of Health and Medicaid to home visiting, hub model integration, crib bumper ban, just a lot of very good evidence-based, well-informed policies, except on the tobacco cessation front. Looking at current General Assembly, we did have the state operating budget go through last year. We had a modest boost in cessation funding in that budget. Kasich, our governor, did propose a pretty good tobacco tax increase, as well as a really good increase on the tobacco product taxes and vapor tax. Those were rejected by the Republican-controlled legislature. We're going to talk more later about the different tax rates and how that works, but there was a really concerted effort, there usually is in operating budgets, to get tax rates up. Senate Bill 106, this is a bill that frankly will not advance in the legislature, but it is a bill that would prohibit smoking in a vehicle if one of the passengers is under age 6. And then lastly, House Bill 302 would allow pregnant minors to consent to health care related to that pregnancy. That bill does have a chance of getting done this year, and we are supporters of that bill. So introduction to tobacco cessation policy. We've had a lot of attention paid to infant mortality. I think a lot of good steps taken, except as it relates to tobacco cessation. And then there, it's been a really uphill battle. Generally, there are 3 ways we can affect smoking in any population. The first are tax increases on cigarettes and tobacco products. The second are funding for cessation programs. And the third is increasing the age of purchase. Again, these are more public policy focused. Obviously, you all in your practice can have an impact on smoking cessation. These are kind of the levers that are available to lawmakers for how we can, put a bill in place or put a law in place to move smoking rates up or down. The legislature is Republican controlled. They've been very hesitant to pursue any tobacco tax increases, as well as despite a generally good economy in Ohio, our tax revenues have not been growing quick enough that we've been able to get significant increases in tobacco cessation funding. And then lastly, while some Ohio cities have adopted tobacco 21 ordinances, we've not seen a concerted statewide push yet. So let's start with the tobacco tax. we in Ohio charge $1.60 per pack or 8 cents per cigarette for cigarettes sold in Ohio. The tobacco tax was first created in 1931, so it's a very old tax. It has seen some recent updates we'll get to on a later slide. The tax rate on other tobacco products, so dip, snuff, chew, snooze, all that kind of stuff, is currently at 17%. That was created in 1993 and it has not received any increase since its inception. Alternative nicotine products are treated differently than tobacco products. So 2 General Assemblies ago, there was a bill introduced, it was backed by the tobacco and vaping industry, and what the bill said was you can't sell a vapor product to someone under the age of 18. And that seems like a really good bill, and we all supported it. What the bill did, though, is it created a new definition in statute for alternative nicotine products that ended up treating them differently for tax purposes than other tobacco products. So what the industry kind of did was, under the guise of let's keep vapor products out of the hands of kids, is to create a tax structure where they only pay the state sales tax, or their consumers rather only pay the state sales tax. So right now, vapor products are taxed as any other good you can buy at 5.75% plus whatever your county adds onto that. In general, tobacco taxes are very popular and really the top priority for the advocate community in driving down smoking. In addition to the public health benefits, we generate revenue for the state. That revenue can then be used to fund cessation programs. So it's kind of a, if we get one, we can usually get both, which is a really good thing. You get a lot of pushback from, conservative-leaning lawmakers, organizations like Americans for Tax Reform, not because they support smoking, but just they philosophically disagree with any tax increase. You also get pushback from the Council of Retail Merchants and the Grocers Association, and yes, the tobacco industry, and they're all very big groups in Ohio. Just so you can see, here's how we compare to other states. I think we're generally, pretty good. Obviously, Michigan and Pennsylvania have higher rates, and we would like to get to a rate similar to where Pennsylvania's at. When you're increasing tobacco taxes, what the research suggests is anything less than, I think it's like 75 or 80 cents at any one time isn't enough of a jump in the price of cigarettes to change behavior. So you need, ideally we would, in the next year, get our tobacco taxes up to $2.60 per pack in line with Pennsylvania. On the other tobacco tax side, we see kind of the same thing. We're sort of upper middle of the pack. Certainly not high, and I think the thing with the OTP rate in Ohio is that it has not been changed since 1983. So for 25 years, it's been the same rate. But generally, we're in decent shape, I think, as a state. Recent updates. So over the last 2 decades, we have seen some modest increases to the tobacco tax. The biggest coming in 2005, where we had a 70-cent per pack increase. And then after that, we only had one other increase, and that was in 2015, we increased 35 cents per pack to arrive at $1.60 per pack. There have been some modest changes to how we tax cigars. Again, that's such a small group of people. And then, again, nothing on other tobacco tax. Our goals, in addition to raising the rate per pack, would be to equalize the rate or increase the rate on other tobacco products so it was more equal to the tax rate on cigarettes, and then also to treat alternative nicotine products as other tobacco products. Moving on, so tobacco cessation funding. Actually, if I can, I'm going to jump back real quick because I had some notes here. So just to put this in perspective, the tax of $1.60 per pack on cigarettes generates $914 million per fiscal year, or around there. So it's a pretty big amount, pretty high dollar. That number jumped from the mid 700 millions because of that 35 cents per pack. So when we have even a modest increase, like 35 cents, you get an almost $200 million jump in the amount of tax revenue that we create. So it's a huge dollar amount spread over a lot of consumers. I can do that math actually real quick. So if we are generating, we have, as we get to a later slide, we're about $12.5 million per year in cessation funding. So, That's a really good question. About 1.4%. That's really low. Which leads me to tobacco cessation funding. Let me just start to get the slide here. So we fund most of our cessation activities through the Ohio Department of Health. There are some other buckets of money at Medicaid and Commission on Minority Health and other funds, but really, if you're talking cessation, you want to focus on the page. We are currently funding our cessation activities 100% through General Revenue Fund. That's the big fund where all your tax money goes. Historically, cessation was funded through tobacco master settlement funds. But that funding source has dried up. So now we're basically reliant on tax revenue, which means GRF spending is about $60 million per year. We are competing, $60 billion with a B per year. We are competing with every other priority and public interest in Ohio. So it's a very competitive environment for us to get funding. The current line item within the Department of Health is funded at $12.5 million per year. This is actually a pretty good increase over funding in recent years. When Governor Case unveiled his budget, in addition to that really nice tobacco tax proposal that we like and we got passed, the House Representatives actually reduced his funding proposal for cessation from $11.1 million down to $5.5 million. And then we worked with the Ohio Senate when the budget went over there to get funding back up to the current rate of $12.5 million. So if you look at where we should be, where the CDC recommends we should be, we're still woefully low, but this is actually the high water mark over the last 2 decades. Here's actually a historical perspective going back to 2008. And so you can see 12.5 million is really the high water mark. And what's even more impressive is that unlike prior years, that is 100% taxpayer funded. It's not coming from the Master Settlement Fund, which means we had to really fight and claw and do everything we could to get that money. That's an estimate for FY 18 and 19. We will hopefully spend somewhere near that. We won't know until July when the fiscal year ends. And then lastly, Tobacco 21. So this is a relatively new thing. It started back in 2014, and this is basically, as you all know, this would be changing the age of purchase for tobacco and vapor products to 21. 95% of adults who smoke begin smoking before age 21. 81% of adults who smoke started smoking before age 18. One of the very common things, a lot of underage smokers are supplied by classmates, typically 18 or 19 years old. So right away you can see if 18 or 19-year-olds can't buy cigarettes, then they can't give them to the 15, 16, 17-year-old underclassmen, and we can start to cut off that pipeline. 2015, formerly Institute of Medicine, now National Academy of Medicine report, found that smoking rates overall would drop by 12%, and smoking rates for 15 to 17-year-olds would be cut by a quarter. That's a pretty significant percentage of smokers that we can get to and turn them off from smoking. So current status, 5 states and the District of Columbia have adopted Tobacco 21 as a statewide law. Now these are unfortunately states where they're heavily Democratic, and frankly this is an issue that it's an easier sell for Democratic lawmakers than Republican lawmakers. But it is impressive that it's gaining steam. I think when I talked about this probably a year and a half ago, it was just Hawaii. So we've had real momentum in a really short amount of time. As of this week, 10 Ohio cities have adopted Tobacco 21, the 10th being Akron, which just did so, I think, on Monday. Those of you in central Ohio will recognize, it's not just Columbus, but it's Dublin, Powell, Grandview, Bexley, Upper Arlington, and New Albany. The challenge with cities doing Tobacco 21 is it's so easy for somebody seeking cigarettes to drive 10 minutes to the township or to the next city over, which is why really, it's great that these cities have stepped up. But I'll pick on Cleveland and say, in Cleveland, if you drive 10 minutes in any direction, you actually probably leave the city limits of Cleveland. So it's pretty easy for you to go to the next town over, or to a township, or to an area that isn't incorporated, and buy your cigarettes. We've actually been active in some of these communities, going to city council, bringing people to and testifying. Nationwide, more than 300 cities have adopted Tobacco 21. So it is very much this grassroots kind of movement where cities have started, and subsequent to that, states have adopted it in response to cities stepping forward. It's something that's been discussed in Ohio. I'm personally very bullish. I think this is a great approach. The legislature, after this election, is going to remain Republican. And they have pretty much said no matter the issue, we're not going to raise taxes on anyone. If the outcome's the same, it's one of those nothing ventured, nothing gained kind of situations. But I think we could some traction on this, especially now you have three major situations. But I think you could get some traction on this, especially now you have three major cities in Ohio that have adopted it. So outlook for 2019 and beyond, with the legislative calendar being very light, I do not expect there to be any major tobacco cessation bills or budgetary bills in the remainder of this calendar year. But in the next General Assembly, which light, I do not expect there to be any major tobacco cessation bills or budgetary bills in the remainder of this calendar year. Assembly, which will be seated in January 2019, we'll have a new governor. And that race is wide open and frankly really weird. We can talk about that. And then we'll have a new House Speaker, hopefully one under FBI investigation. It's a weird 2 weeks in Ohio, I swear. But the budget is always ideal for tax discussions. The budget is always ideal for tax discussions and cessation funding increases and all that kind of stuff. And I think there's a real potential for tobacco 21 bills to be introduced in the next General Assembly. It's just the politics are what they are. We don't make policy in a vacuum. We're going to be competing with a lot of other issues. But as infant mortality continues to be a challenge in Ohio, we've done some great things legislatively. Are what they are. We don't make policy in a vacuum. We're going to be competing with a lot of other issues. But as infant mortality continues to be a challenge in Ohio, we've done some great things legislatively, but our rate is still stubborn and high. So I think legislators are going to have to go back to the drawing board and look at other ways to address this issue. And one big untouched area is tobacco cessation. We'll be there no matter what. We've got a lot of folks that are really excited about this, but we've got our work cut out for us. So with that, got too long-winded. Are there any questions? Yes, Sam.
So I'm going to tell me the evidence that funding for tobacco cessation is cost effective. Should Ohio spend my money on tobacco?
Well, we can point to, we fund these programs. If we get smoking rates down, we save X amount of dollars. I'll actually, to a degree, that's a hard argument to make. Because one thing we struggle with, whether it's tobacco cessation or tobacco tax increases, we know that we do those things, we can prove that the smoking rates go down, and we can project we save X amount of money because fewer people smoke. The challenge is, after we get to that dot, connect the dots, the next dot would be, okay, now we want to go back to the state and show them that, hey, we're spending less now on Medicaid, for example. We never get to that. So we've not figured out how to show legislators, hey, because you increased tobacco taxes in state fiscal year 2015, we saw this drop in smoking, which means you can spend this million less on Medicaid. But when we go in with our studies and our data and we say, look, we know if we spend more money on cessation, we can get more. There's a cause and effect there. But frankly, it's a really hard argument to make. I think a lot of why we got the funded increase we got is because legislators didn't want to touch the tax piece, but we had AAP and Children's Hospitals and Heart, Lung, and Cancer and all these groups coming forward, hounding them for something, and they basically, okay, we'll give you some money. So it's not that. But, it's a hard argument to make because we never see that final piece, which is spending less on healthcare in the future. The state spends in Medicaid $12 billion a year. So if we can make that $12 billion, $11 billion, $800 million, that would really move the needle. We've not been able to get those dots connected and move it back. But that's a good question. Challenge with every 2 years when we do the budget.
And I have a question about the different tax rates in different states. Is there a correlation between if you tax one state higher, does that lower the smoking rates?
So generally, yes. It's a little murky because you have to kind of look at what was the smoking rate in that state and then how much were they increasing their rates. I can tell you our smoking rates should be lower than Georgia and North Carolina and Tennessee because those rates, there was never that big enough boost to get smoking behavior to go down, to get consumer behavior to go down. But I guess the short answer is yes, our smoking rates should be lower than those states, but I think there's a lot of variables that might change that. And that's probably getting to a level of policy detail and healthcare data that I'm not too comfortable with. So.
No, I'm just wondering because I know the whole United Kingdom has enacted, I see the world through obesity, so I apologize, but they've enacted a countrywide sales tax on sweetened beverages.
Yeah.
So, it's interesting to see really if there's that correlation to behavior change.
Yeah, a lot of it depends on. Oh, hello. Yes.
Adolescents are definitely cost sensitive, so that is clear. I don't have the exact article, but it's very clear that totally works for adolescents and recovery. That's a really big area. And then I saw one article about birth outcomes in states that have higher taxes were improved. So it looks like pregnant women also may be cost sensitive. So those are two really important areas. And yeah, it's a very difficult, analysis to do, because I agree, like, there could be a state that has a lower tax, but it's also a tobacco state, historically a tobacco state. So you have to, it's a complicated analysis, but I can leave you with the knowledge that adolescents are cost sensitive and most likely pregnant women are cost sensitive.
Another issue that just reminded me is I know anecdotally smoking rates are typically higher in Cincinnati than they may be in other, like Columbus. And the reason is, if I'm in Cincinnati, I can drive right across the river to Kentucky and get cheaper cigarettes. So if you're really that worried about the price, you can go across the river. Columbus, being in the center of the state, if you don't like the tax rate in Ohio, you're driving 3 hours to the border to get your smoke. So that is something, you do see with the map, and why it's so important we look around us is, smoke rates aren't that bad in Toledo because going to Michigan isn't really going to save you any money. Smoking rates aren't as bad in Youngstown because going across the border isn't bad. But, there is that border issue, especially in Cincinnati. So any other questions? All right. And then, am I supposed to go through the questions?
So we are going to ask Dr. Garner to come up and start with her questions, and then we'll throw it back to you, Danny, to go through yours. So if you are looking for the MOC Part 2 credit, there's a form in your packet.
Yes. All right. It should be too hard. All right. First one. All of the above. Yes. Great. That's all of it. Okay, the next one, there was a little controversy, but the number that I stated was 50%. Very nice. And then this one also false. Okay, great.
Okay, what percentage of adult smokers began smoking before they were 21? 95. How many Ohio cities have enacted tobacco 21 laws?
Not enough.
Yeah, when I made this presentation, I put 9. You put the 10 on as a throwaway, and I'll trip up, and then of course action I go. I can tell the future. The current tax rate for cigarettes? 60. All right, thank you.
So thank you to our speakers. It was great to hear not only legislative efforts, but also some of the ins and outs of smoking prevention in our primary care setting. Which leads me to, I'm like Vanna White, I get to publicize 2 of our programs that you might not have heard about, and just to give you a little bit of some background. The first is Smoke-Free Families. So Smoke-Free Families, which is very timely in the discussion today, it's a program sponsored by Medicaid and the Ohio Department of Health. And the idea of the program is to have pediatricians screen families for smoking in the home for children 0 to 1 year of age. And then if the family screens that there is smoking and or other smoking in the house, then it's the idea is to counsel them and get them into a program to be able to quit smoking. It's been incredibly successful. We had a lot of practices in wave 1. So if you participated in wave 2, we've already worked out a lot of the kinks in the program. There will be some patient incentives for participation in this wave. So it's nice to be able to give some incentive to a family to try and encourage them to quit. And we have an easy data collection form. Families just fill out the form, and then it can get scanned or faxed in, and it automatically gets put into a data system. So it's a really nice way to learn how to handle smoking cessation with families in your practice. It's an easy way to get involved. You get some incentives for families, and you get 25 points MOC4 credit. If you are interested, Kristen, in the back of the room, is our program manager. We will be launching this at the Ohio AAP annual meeting. So if you come to annual meeting, you can then stay and just actually enroll and be a part of this MOC4 program. There are also some MOC2 opportunities when you participate.
And there is an enrollment form in your folder that does not lock you in, but just please fill that out if you're at all interested, and I'll follow up with you after the meeting next week.
And if you know of someone else that might be interested or other partners, feel free to pass it along as well. If you give us people's names, we're happy to follow up with them, whether, just so that we can at least get the foot in the door to have some conversations. And the other program that we just wanted to introduce is our TRAIN program. This is our program manager is Haley Southworth. She's working with Jonathan Thackeray on this program. It's really a way to identify kind of sentinel injury events. There's been a lot of literature of if you undress patients, you actually can do a exam on younger patients. You can actually pick up these sentinel events. And so it's a study that we're trying to see whether we can look in the primary care setting, try and identify these families early on. This also is, you'll get 25 MOC4 points. You can get up to 30 MOC2 points. The kickoff is on June 5th, and Haley would be your contact person. They have something. So I am here. If anyone has any questions about any of these programs, I'm happy, or Kristen or Haley, happy to talk to you afterwards, and hopefully you'll sign up and be a part. Thank you.
Thank you.